Hello, ladies and gentlemen. This program subject is T-cell lymphomas. For public health education, sourcebook the MD Anderson Manual of Medical Oncology. Peripheral mature T-cell lymphomas. The term peripheral T-cell lymphoma is used to describe lymphoid neoplasms of mature T-cell lineage as opposed to tumors of thymic origin. The terms post-thymic and mature T-cell lymphoma also have been used to describe these tumors. Peripheral T-cell lymphomas represent approximately 10% of all non-Hodgkin lymphomas in most European and United States studies, but are more common in the other parts of the world. Incidences are higher in Asian populations, possibly related to high prevalence of human T-cell lymphotrophic viruses type 1 and Epstein-Barr viruses. Some rare types of T-cell lymphoma, and we would like to pass some subjects and detail for physicians, doctors. Future direction for T-cell lymphomas. T-cell lymphomas represent a heterogeneous group of diseases with poor prognosis. Therapeutic progress has been slow due to the rarity of the disease. It is strongly recommended that patients with non-ALK positive ALCL and PTCL and CTCLs receive treatment on clinical trials so that progress can be made in management of the uncommon neoplasms. Therefore, future studies will require multi-institutions collaborations. New subject, Hodgkin lymphoma. Hodgkin lymphoma The management of Hodgkin lymphoma continues to change. Before the widespread use of modern polychemotherapy, radical radiation therapy alone cured many patients. However, reliance on radiation alone required extensive radiation portals to treat nearly the entire lymphatic system with radiation doses up to 44 gray. With long-term follow-up, many of these patients developed heart toxicity and second malignancies. Over the past 10 to 20 years, efforts have been made to reduce the long-term toxicity of treatment for Hodgkin lymphoma, while maintaining excellent cure rates with modern chemotherapy. Multiple randomized studies have shown the radiation portals can be safely reduced from extended field radiation to involve field radiation. This is very important to reduce the risk of secondary breast cancer in young women. The majority of breast exposure to radiation is from treating the axillary nodes with large mantle fields, because most women with early stage Hodgkin lymphoma don't present with axillary adenopathy. Eliminating radiation the axilla will decrease the risk of secondary breast carcinomas. In addition, several centers are using novel treatment techniques such as innovative patient positioning system to move the breast out of the field. Intensity modulated radiation therapy and proton radiation to further reduce exposure of normal tissue to radiation. Currently, the European Organization for Research and Treatment of Cancer has further reduced the radiation portals from involved field to involved nodal radiation, where the portal is tailored to the involved node only and not the entire lymph node region. In addition, studies are also currently underway to determine if it is possible to reduce the radiation dose after chemotherapy from 30 to 20 gray. Thus, the radiation portals are much smaller, more conformal, and the doses are lower than those 20 to 40 years ago. In multiple studies in patients with early stage Hodgkin lymphoma, the complete omission of radiation therapy resulted in the inferior outcome in the future. Functional imaging such as positron emission tomography may allow the identification of patients in whom radiotherapy can be eliminated, but this is still being examined in carefully controlled clinical trials. However, radiation therapy with greatly revised techniques and lower doses will likely continue to play an important role in the management of Hodgkin lymphoma. Type of Hodgkin lymphoma: nodular lymphocyte predominant, classical Hodgkin lymphoma, nodular sclerosis, lymphocyte rich, mixed cellularity, lymphocyte depleted. So much detailed information about physicians and medical staff, doctors. Treatment of Hodgkin lymphoma: response assessment, positron emission scan, and different activity, chemotherapy alone, combined modality therapy, and different Radiotherapy. Very deep information, detailed, and very heavy, strong. And I must to passing so many subjects because very detailed and not useful for public health education. But lastly, I would like to finish this subject with conclusion. Hodgkin lymphoma remains one of the most treatable human malignancies. A wide range of therapeutic modalities available, including chemotherapy, radiotherapy, and combination of the two. Many new and promising therapeutic agents are currently under investigation. Clinical research. Controversies remain as to the appropriate treatment of Hodgkin lymphoma at different stages, but the debate may be resolved with future studies. Finally, the improved outcome of patients with Hodgkin lymphoma make it imperative to consider the acute and long-term side effect of each therapeutic modality in treatment planning and future clinical trials. Other subject, multiple myeloma and other plasma cell dyscrasias. Multiple myeloma and other plasma cell dyscrasias. Plasma cell dyscrasias are a group of diseases with malignant proliferation of monoclonal population of plasma cells. These cells may or may not secrete detectable levels of the monoclonal immunoglobulin or paraprotein, commonly referred to as M protein, although the most common plasma cell dyscrasia is monoclonal gammopathy of undetermined significance. MGUS. Closely related disorders include multiple myeloma, solitary plasmacytoma of bone, extramedullary plasmacytoma, Waldenström macroglobulinemia, primary amyloidosis, and heavy chain. This is the spectrum of MGUS, solitary plasmacytoma of bone, and asymptomatic and symptomatic multiple myeloma may actually represent the natural progression of the same disease. The chapter focuses on the etiology, diagnosis, clinical features, and current therapy for multiple myeloma and other plasma cell disorders. Since the publication of the first edition in 2006, there has been much progress in the understanding of the biology of the multiple myeloma and in its treatments. New diagnostic criteria have been developed and international staging system has replaced the Dury-Salmon staging system. The role of single and double autologous stem cell transplantation has been clarified by randomized trials. Most important, thalidomide bortezomib, lenalidomide, and liposomal doxorubicin have emerged as new active agents and are rapidly being incorporated into the treatment of both newly diagnosed and relapsed MM. Multiply myeloma. Multiply myeloma is malignant proliferation of monoclonal plasma cells that produces a monoclonal immunoglobulin. The immunoglobulin secreted in the majority of cases is immunoglobulin G. 60% of immunoglobulin A is secreted in 20%, immunoglobulin D in 2%, and immunoglobulin E less than 0.1%. B clonal secretion 1% less than is rare. Secretion of light chain only is noted in 18% and 5% less than 5% of patients don't secrete an M protein. Non-secretory MM. Epidemiology. The National Cancer Institute estimates that 20,580 people will be diagnosed with multiple myeloma in the United States in 2009, and there will be 10,580 deaths from the disease. The median age of diagnosis is 70 years. The incidence is highest in the age range of 75 to 84 years, 27.6%, followed by the 65 to 74-year-old range, 26.5%. The annual age-adjusted incidence of the disease per 100,000 populations is 6.6 among white men and 4.1 in white women. Among African Americans, the frequency doubled to 14.3 in men and 10 in women. Similarly, there is a difference in mortality by racial group. The annual age-adjusted mortality rate per 100,000 is 4.3 and 2.7 in white men and women, respectively. This rate increases to 8.2 and 5.8 in African American men and women, respectively. Etiology. No predisposing events appear to be important in the etiology of MM. Some events that have been suggested include radiation exposure in radiologists and radiumedial workers, occupational exposure in agricultural, chemical, metallurgical, rubber plant, pulp, paper workers, and leather tanners, and chemical exposure to benzene, formaldehyde, epichlorohydrin, hair dyes, paint, spray, and asbestos. Most of these associations have been countered by negative correlations. Initially, it was reported that survivors of the atomic bombing of Hiroshima had a greater risk of developing myeloma, but longer follow-up data now refute any evidence of increased risk among survivors. Some reports suggest that lower level prolonged radiation exposure over many years may have caused some cases of multiple myeloma, among radiologists and radium HDL painters. However, no relationship has been shown between the incidence of multiple myeloma and exposure to diagnostic X-rays or therapeutic radiation. Another factor previously thought to be associated with myeloma was intestine prolonged exposure to benzene, such as was experienced by unprotected workers in the rubber industry. Although the relationship of benzene and its metabolites to the occurrence of leukemia has been accepted, benzene's relationship with myeloma remain unproven. Although myeloma is not an inherited disease, there have been numerous case reports and studies of multiple myeloma occurring in the same family. Lynch et al. Reported a family with 5 cases of myeloma, 3 cases of MGUS, and 5 cases of prostate cancer in 2 generations. A case control study of over 37,000 first-degree relatives of multiple myeloma patients in Sweden found that these relatives had twofold increase in the risk of developing myeloma compared to controls. Similarly, an increased risk of myeloma was also found in first-degree relative of 218 myeloma caused in family registry study conducted in Iceland. Although these studies are suggestive, no clear genetic alteration has been demonstrated among patients with myeloma, and the role of genetics in the development of myeloma is evolving. Clinical features. The clinical presentation of multiple myeloma is quite variable. Bone pain, especially from compression fractures of vertebra or ribs, is the most common symptom. Findings that suggest a diagnosis of multiple myeloma include lytic bone lesion, pathological fracture, lytic bone lesions, anemia, azotemia, hypercalcemia, and recurrent infections. However, approximately 20% of patients with multiple myeloma are free of symptoms. These symptoms general hypercalcemia from time to time 30% nearly, anemia general, and other weight loss or exhausting, and some different conditional problems general symptoms of cancer disease, chronic disease, but localized of type cancer, various symptoms should be possible to show us. Bone disease, hypercalcemia, renal failure, anemia, infection. Some detailed therapeutic modality that not interested the public health education. Yes, and last subject conclusion. There have been many recent advances in the understanding of plasma cell dyscrasias, the origin of myeloma from a primordial stem cell is suggested by phenotyping expression of early precursor. Various cytokines are produced that may serve as myeloma cell growth factors or osteoclast activating factors. Better understanding of the prognostic factors of the myeloma, markers of drug resistance, lactate dehydrogenase and chromosome 13 deletion, loss of genetic materials and information, and measures of tumor cell masses has helped to identify patients who may benefit from novel therapeutic approaches. Recently, the addition of several novel therapeutic agents including thalidomide, bortezomib, and IMiDs have added new hope for improved survival in multiple myeloma. In addition, synergy of new and old agents, despite prior resistance and myeloablative therapy with autologous stem cell support, provide many options for effective treatment of multiple myeloma, Waldenström macroglobulinemia, and heavy chain disease have been treated with alkylating agent, but cladribine appears promising for superior long-term results. Further studies are needed to understand the etiology and biology of plasma cell dyscrasias in order to develop more effective agents and regimens for controlling these disorders and to justify immunologic and other procedures for sustaining long-term control. That's all this program. Thank you very much. I hope should be possible for you useful. Of course, difficult, but generally I would like to expression just superficial, not detailed, and very deep, very heavy, very difficult information, just superficial. General information, general, not therapeutic modality, step by step, should be possible to understand. And cancer disease, cultural richness should be possible step by step with time. Thank you very much. You are patient. Thank you so much. See you soon. See you again.